Hi, my name is Congenital and you're watching the video Fourth Cranial Nerve Palsy, Characteristics of a Congenital Palsy. In this video, we will be distinguishing between a recently acquired fourth nerve palsy and a congenital palsy or a long-standing fourth nerve palsy. So in the previous video, we focused on the patient who had an acquired neurogenic palsy or an acquired fourth nerve palsy, and one that was recent and unilateral. And so we discussed the characteristics we would expect in this patient. In this video, we're going to concentrate on the congenital patient and the long-standing fourth nerve palsy. The long-standing fourth nerve palsy shares very similar features to the congenital fourth nerve palsy, which is why we're doing this or discussing this in the one video. Now, much of what we're about to discuss in relation to how to distinguish a congenital from a recently acquired fourth nerve palsy, we have discussed in the video regarding the principles of differential diagnosis. So in this video, some of the information will be relatively known and generic, and in other instances we'll be extending what you know into specifically fourth nerve palsies. The other point to make here is that this video will not focus on distinguishing between unilateral and bilateral fourth nerve palsies, either acquired or congenital. The focus will be on what are the distinguishing features between the long-standing and congenital fourth nerve versus a recently acquired fourth nerve palsy. So let's begin with the history of the patient. So as we've mentioned previously, with a congenital fourth nerve palsy, the history regarding the fourth nerve is relatively vague, and the patient generally struggles to be able to give you a distinct timing of onset of the fourth nerve or can't associate it with any particular event. With the long-standing fourth nerve palsy, in these instances there may be a more distinct cause, whereby sometimes you might see a patient who did have a closed head injury, say 5-10 years ago, where they had diplopia at that time, and now you're seeing them many years later, but you actually have a history to go back on as to the onset of the deviation. However, what is in common between the congenital and the long-standing is generally their complaint isn't about diplopia, but rather more about their abnormal head posture or the appearance of the abnormal head posture. Sometimes the complaint may be regarding diplopia. However, in these instances, it's usually a decompensating fourth nerve palsy. I'll come back to the concept of a decompensating fourth nerve palsy a little bit later in this video. But overall, history will be vague for the congenital fourth nerve palsy. It may be distinct for the long-standing fourth nerve palsy, and invariably many of them will present with the complaint around cosmesis rather than the complaint regarding bothersome diplopia. Now, where you're not sure whether the patient has a long-standing or congenital fourth nerve palsy, as suggested previously, always go back to the family album test and look at photos of the individual when they were infants or children. If we look over to the right, we have here an individual who, as an infant, was tilting to the right, and then also as a young child tilting to the right, indicating this is likely to be a congenital palsy. In the second image here, we've got 4 brothers, and what we can see is 3 of the 4 are tilting to the left. But again, in this instance, we've got confirmation that the individual had this problem early on in life or as a child. If they present to us as an adult and we're trying to work out whether this is long-standing or congenital versus a recently acquired palsy. So look at the head posture and look at the family album should you have doubts about the onset. Another feature of a congenital fourth nerve palsy, or one that's long-standing and generally one that developed as a child, is facial asymmetry. Now, what this means is that the distance between the lateral canthus and the corner of the mouth is reduced on the side of the head tilt. In the patient we see here, there is a very marked facial asymmetry. Most patients won't have such marked facial asymmetry, but it's a good example to work through the characteristics of the facial asymmetry. So what we see here in primary position is that the patient has a right hyper deviation. And then if we take the lateral canthus of the left eye, we see that the distance between the lateral canthus and the corner of the mouth here is shorter than the distance of the lateral canthus of the right eye and the corner of this mouth. And this patient has developed facial asymmetry from the chronic tilting of the head to the left. In the schematic diagram here to the right, what we can see is that if you ask your patient to hold their head straight and you take a straight line across the face, if you then take a line across the centre of the eyes, what you will find is an acute angle that represents the facial asymmetry we're discussing. Okay, moving on to the cover test and ocular movements. In terms of patients who either have congenital or long-standing fourth nerve palsies, they are likely to have large hyperphorias, the distinction being a latent deviation, and at times this can actually exceed 20 diopters. Now we know that the vertical fusion range is relatively small. It's only up to about 4 prism diopters. So for a patient to be able to control 20 diopters of vertical deviation indicates that they have an extension of their fusional amplitude. So if you were to go to assess their fusion, whether in free space with a PCT or a synoptophore, what you would find is these extended fusion ranges in the vertical direction. And what we see here to the right are images of patients with relatively large vertical deviation. In this instance, they're manifest and not controlled, but in a congenital long-standing fourth, what we would see is control of these deviations with or without the head posture. The other thing that you will be aware of is that with congenital long-standing fourth nerve palsies, the deviation will become relatively concomitant, such that the primary deviation will be relatively equal to the secondary deviation. Again, as you're aware, this will make it difficult for you to determine the primary deviation and to perhaps determine the primarily affected muscle when assessing the patient. And lastly, in relation to ocular movements, note that contracture of the ipsilateral antagonist, in this instance the inferior oblique, can occur with long-standing fourth nerve palsies. The other thing to be aware of is that long-standing fourth nerve palsies can also cause a tight superior rectus of the same eye that's palsied, so the ipsilateral superior rectus. Our understanding of why this happens is limited. However, if you think about the deviation, say for instance we've got a left superior oblique palsy, that eye will be hyperdeviated. Now that constant hyperdeviation may be what's causing the contraction of the superior rectus. The absence of torsion is a hallmark of a congenital fourth nerve palsy. So as we've previously discussed in other videos, if you see objectively excyclotropia and the patient is not experiencing subjective torsion, then what you have here is a patient with a congenital fourth nerve palsy, or at least one that developed during childhood. Now earlier we mentioned that the patient has an extended fusion range. This actually means that they will generally also have an area of BSV that's larger than expected. And this also is what protects these patients from having symptoms regarding diplopia. Their large fusion ranges are giving them more area of BSV and therefore giving them more comfortable vision and BSV. And finally, a patient who has a congenital fourth nerve palsy or a long-standing fourth nerve palsy that began when they were a child is at risk of suppression and amblyopia. If the patient is controlling the fourth nerve through their fusional capacity, or if they're controlling the deviation with an abnormal head posture, then the patient becomes less likely to develop amblyopia and suppression. It will be dependent on how frequently the patient is manifest. So say, for instance, a patient doesn't always utilise the abnormal head posture and sometimes keeps their head straight, at which point they become manifest. It is possible for them to begin suppressing in this position and thereby develop amblyopia. In general, a lot of these patients will have an area of BSV and maintain BSV, which will be protective against amblyopia suppression. However, the presence of suppression amblyopia are an indicator clearly that this has occurred during the critical period when the individual was a child. Now, before we move on, I'd like us to discuss the cause of a congenital fourth nerve palsy. Now, you've seen the video on the etiology of neurogenic palsies, and we've seen that a variety of conditions such as diabetes or space-occupying lesions or trauma can cause a fourth nerve palsy or a neurogenic palsy. However, for the fourth nerve palsy that's congenital, it tends not to be any of these reasons. It tends to be an anomalous tendon, specifically a floppy tendon, sometimes also called a lax or redundant tendon. About 90% or almost 90% of patients who have a congenital fourth nerve will be found to have a floppy tendon. Now, the only way to find out that the tendon is floppy is in theatre when the superior oblique is explored. So what this is essentially, if we take a look here to the right, is that the tendon here is, as we say, floppy. It's not as tight as it should be. This creates a weak superior oblique, which explains the fourth nerve palsy. However, there are a couple of other causes related to the tendon that can cause a fourth nerve palsy or congenital fourth nerve palsy, and Von Norden and Halverston have come up with a classification system for this. So the class 1 is the patient with the floppy tendon. But another reason is that the tendon may also be misdirected, and we can see that here in this image. The other possibility is, again, it's misdirected, but is actually in the tenons. And finally, there are patients who may have an absent tendon. So in all these instances, the effect is a superior oblique underaction or palsy of the superior oblique. Again, you will not be able to determine the cause of the palsy or the congenital fourth nerve until the patient is in theatre and that superior oblique is explored. However, as a clinician, you would assume that the patient has a floppy tendon until proven otherwise, given the statistical possibility that it is a floppy tendon. Okay, now I earlier mentioned a decompensating superior oblique palsy and talked to you about the fact that these are the patients who may come to you with diplopia. So just as in concomitant strabismus, we've talked about patients who might have an exophoria or an esophoria who decompensate and become intermittently manifest. This can also happen to your superior oblique palsies. The congenital superior oblique patient, or the patient who has a congenital superior oblique palsy or a long-standing superior oblique palsy, has learnt, in most instances, to control the deviation, whether with the abnormal head posture or without the abnormal head posture. Now, with time, sometimes patients may struggle to continue controlling the deviation and begin to decompensate. In these instances, the patients will come to you with diplopia. Usually it's intermittent, and it will also be associated with those types of asynoptic symptoms that we do see in patients who are decompensating, those headaches, those eye strain complaints. Now, the way you'll work out that the patient has a decompensating superior oblique palsy is that the presenting complaint will be diplopia and asynoptic symptoms, and as you go to investigate the patient, you will discover that they have a fourth nerve palsy and they will have the hallmark features of a congenital or long-standing fourth nerve. For instance, if you measure their fusion range, you're likely to still find it to be larger than 4 prism diopters, despite the fact that they may be struggling to control. You will usually find extended fusion ranges. So look for all those things that you usually do for a congenital fourth nerve palsy, and you'll be able to put the picture together to diagnose the patient with a decompensating superior oblique palsy. In summary, here is a table that distinguishes the patient who has got congenital fourth nerve palsy or a long-standing fourth nerve from that of a recently acquired fourth nerve palsy. So again, in terms of history, look for a vague history where the onset's not very well known, and the general complaint being around cosmesis rather than diplopia, unless we have a decompensating fourth. Look at the old photographs. If the individual had the deviation as a child, or if it's congenital, then we're looking at abnormal head postures being present in childhood photos. In terms of facial asymmetry, particularly those with a congenital fourth nerve, or again those who have developed the fourth nerve during childhood, will present with facial asymmetry. And subjective torsion is not experienced by patients who are congenital, and the vertical fusion range can be quite large in patients with long-standing or congenital fourth nerve palsies. That brings us to the conclusion of this video. Thank you for watching.